Good morning, respected faculty and dear colleagues. Just imagine this for a moment. Every single day, abnormal cells arise in our body. Some of them carry mutations, have the potential to become cancerous, but most of them never become true tumors. Why? Because before we notice them, before scans detect them, before the symptoms appear, our immune system silently identifies them and destroys them. This invisible battle happening continuously inside our body is called as immune surveillance. But oral cancer presents a fascinating and a dangerous paradox. The tumor does not simply grow faster than the immune system, it actually learns how to hide from it, manipulate it, and eventually turn the immune system into an ally for the tumor progression. Today in this seminar, we'll explore how this happens from the normal oral immune microenvironment to the highly immunosuppressive tumor microenvironment in the oral squamous cell carcinoma. I shall cover the seminar under the following contents. As James Ellison, the Nobel Prize winner in immunotherapy, famously said, tumor cells are essentially normal cells that have learned to hide from the immune system. Now, the concept of immune surveillance was first proposed by Burnett and Thomas in the 1950s. It describes the immune system's ability to continuously recognize and eliminate the newly transformed cells before they become clinically detectable cancers. However, in the oral squamous cell carcinoma, this protective mechanism which is there, it gradually fades. The tumor cells over here, they exploit the immune checkpoints, recruit suppressive immune cells, and create an environment that favors immune evasion rather than immune destruction. And this altered ecosystem is what we call as a tumor microenvironment, or the TME. Now coming to the epidemiology. According to the Globocan 2022 estimates, the head and neck squamous cell carcinoma is the seventh most common cancer globally. India carries one of the highest burdens of this cancer worldwide, largely due to the use of tobacco and areca nut. In fact, tobacco-related habits which are there, they account for 80% of the head and neck squamous cell carcinoma cases in India. This is especially important for us as oral health professionals because we are often the first clinicians to detect these lesions during our routine examinations. The tongue and the buccal mucosa, they remain among the most commonly affected sites. So why is it understanding the immune surveillance so important? Despite the advances in surgery, chemotherapy, and radiotherapy, survival rates in oral cancer still remain poor. And one major reason is that this tumor microenvironment actively suppresses the anti-tumor immunity. This brings us to the concept of cancer immunoediting, described by the three E's, which are elimination, equilibrium, and escape. Initially, the immune cells which are there, they will eliminate the transformed cells. Some tumor cells are now going to survive and remain dormant in equilibrium. Eventually, the resistant clones which emerge that completely escape this immune control and establish clinically evident cancer. Understanding this progression forms a basis for modern immunotherapy. Our oral immune microenvironment. Now, before understanding the tumor microenvironment, we need to understand the normal oral immune microenvironment. Oral cavity is constantly exposed to microbes, food antigens, environmental insults. So the oral mucosa acts as a very specialized immune barrier. Saliva here plays an important protective role through the secretory IgA, mucins, and antimicrobial enzymes. The gingival clavicular fluid contains leukocytes, immunoglobulins, and contributes to defense. Langerhans cells and dendritic cells capture antigens and migrate to the lymphoid tissue where they activate the immune responses. Under normal condition, the system maintains a very delicate balance between immune activation and immune tolerance. Now, oral carcinogenesis is not a sudden event. It is a multi-step process which occurs over several years through accumulation of genetic and epigenetic alterations. The key mutations over here involve the TP53, EGFR, the Notch1, cyclin D1. Initially, only a small population of the keratinocytes which are there, they will become transformed. Over time, under selective pressure from the surrounding microenvironment, more aggressive clones survive and they expand. Eventually, these cells they acquire the hallmarks of cancer, which are limitless proliferation, resistance to apoptosis, angiogenesis, invasion, and metastasis. And importantly, this evolution is strongly influenced by the TME. The tumor microenvironment is not made up of tumor cells alone. In fact, non-tumor cells they can also comprise up to 90% of the tumor mass. This environment includes the immune cells, the fibroblasts, endothelial cells, extracellular matrix, cytokines, and chemokines. There is a constant communication that occurs between these tumor cells and the surrounding stromal cells. And instead of fighting the tumor, many of these cells which are there, they become reprogrammed to support the tumor growth. Among the immune cells, the tumor-associated macrophages or TAMs are particularly important. Now the macrophages, they exist in two broad phenotypes. M1 macrophages, which are anti-tumor and inflammatory. The M2 macrophages, which are pro-tumor and immunosuppressive. In oral cancer, TAMs predominantly resemble the M2 phenotype. Now these M2 macrophages which are there, they promote angiogenesis through the vascular endothelial growth factor, invasion through the matrix metalloproteinases, immune suppression through the interleukin 10 and the transforming growth factor beta, and a resistance to therapy. So essentially, these macrophages that should destroy the tumor begin protecting it instead. And a high TAM infiltration is associated with poor prognosis in OSCC. Dendritic cells. Dendritic cells are often called a bridge between the innate and the adaptive immune cells. Now their role is to capture the tumor antigens and present them to T cells. But tumors, they interfere with this process. The TME releases suppressive mediators like VEGF, interleukin 10, TGF beta, and prostaglandin E2, which impair this dendritic cell maturation and their migration. As a result, the T cell activation becomes defective, weakening the anti-tumor immunity. This is one reason why dendritic cell-based cancer vaccines are being actively explored therapeutically. Next, we move is to the natural killer cells and neutrophils. Natural killer cells, they normally destroy the abnormal cells without any prior sensitization. But the tumors, they suppress this natural killer cell activity through checkpoint signaling and immunosuppressive cytokines. Neutrophils, they also show dual behavior. So we have the N1 neutrophils which are anti-tumor and the N2 neutrophils which are pro-tumor. Now as this tumor progresses, the microenvironment will shift from the neutrophils towards the N2 phenotype. These cells release proteases and neutrophil extracellular traps or the nets that promote invasion and metastasis. Clinically, a high neutrophil to lymphocyte ratio is associated with poorer prognosis in the head and neck cancers. Then we have the myeloid-derived suppressor cells. One of the most suppressive cell population in the cancer are these myeloid-derived suppressor cells or the MDSCs. These cells inhibit the T cell function through multiple mechanisms: depletion of the amino acids, production of reactive oxygen species, the PD-L1 expression, and the induction of regulatory T cells. They also promote angiogenesis and metastasis. Importantly, a high MDSC levels correlate strongly with resistance to immunotherapy. Regulatory T cells, or the TREGs, are essential for maintaining the immune tolerance, but in cancer they become major drivers of immune evasion. TREGs suppress the cytotoxic T cells using interleukin-10, TGF-beta, CTLA-4, and adenosine pathways. A high TREG infiltration is associated with a poor prognosis and therapy resistance in most of the solid tumors, including the oral squamous cell carcinoma. Therefore, many new therapies aim to reduce the TREG-mediated suppression. Now coming to the stromal cells, the cancer-associated fibroblasts, or the CAFs, are among the most abundant non-immune cells in the TME. Normally, fibroblasts help in wound healing, but tumors permanently activate them. And as many researchers say, tumors are wounds that never heal. CAFs promote extracellular matrix remodeling, angiogenesis, invasion, chemoresistance, and immune suppression. They also create dense fibrotic barriers that prevent effective drug penetration. In oral squamous cell carcinoma, a increased CAF activity which strongly correlates to aggressive disease and recurrence. The extracellular matrix which is there, it's not just a structural support. It actively influences the tumor behavior. Components like collagen and fibronectin, they create pathways for invasion. Matrix metalloproteinases degrade the ECM and felicitate metastasis. At the same time, a rapid tumor growth causes hypoxia. Now, hypoxia activates the HIF-1 alpha, which stimulates the vascular endothelial growth factor and angiogenesis. Tumor cells then switch to anaerobic glycolysis. That's a Warburg effect, which allows survival even in a low oxygen level. Unfortunately, hypoxia also increases resistance to chemotherapy and radiotherapy. So, oral cancer is not simply a disease of mutated immune epithelial cells. It's a disease of an entire ecosystem. The TME continuously evolves through complex interaction between the tumor cells, immune cells, stromal cells, cytokines, and the extracellular matrix components. This environment drives three major processes, that's immune evasion, angiogenesis, and metastasis. Understanding these interactions is essential because modern cancer therapy is no longer focused only on destroying the tumor cells. It is increasingly focused on reactivating the immune system and reprogramming the tumor microenvironment. And the shift which has taken place has opened the door to targeted immunotherapies that may significantly improve the outcomes in oral cancer patients in future.
Good morning, everyone. I'll be continuing the second part of the seminar. My colleague has briefly introduced you to tumor microenvironment and cancer immune surveillance. I'll be continuing with cancer immune editing, the three E's: elimination, equilibrium, and escape. A normal epithelial cell in the oral cavity suddenly becomes abnormal because of chronic inflammation, carcinogens like tobacco, alcohol, or viral changes. What happens next? The immune system immediately notices this abnormal transformation. This is called elimination phase or immune surveillance. Here, the natural killer cells and cytotoxic CD8 T cells acts like body's security forces. Natural killer cell check whether the tumor cell has lost MHC class 1 molecule. At the same time, cytotoxic T cell recognizes tumor antigen presented on HLA class 1 molecule and directly destroy these transformed cells. So initially, the immune system is actually successful in controlling cancer development. But the cancer cells are intelligent survivors. Some cells escape the destruction and enter the next stage called as equilibrium phase, a state of dynamic balance where the immune system prevents clinical outgrowth but cannot fully eliminate the tumor. This explains long-term clinical dormancy and asymptomatic residual disease. Now comes the most dangerous stage, the escape phase. At this point, the tumor cell learn how to hide from the immune system. They basically switch from being visible enemies to invisible enemies. One major mechanism is upregulation of PDL1. When PDL1 binds to PD1 receptor on T cell, the T cell becomes exhausted and inactive. So even though the immune cells are present, they stop attacking the tumor. The tumor cell also reduces HLA class 1 expression, preventing antigen presentation and avoiding recognition by cytotoxic T cells. Another mechanism is downregulation of TAP1 and TAP2 protein, which further impairs antigen presentation. In addition, the tumor creates dense stromal barriers and immune suppressive cytokines, making it difficult for immune cells to penetrate the tumor tissue. As a result, the tumor successfully escapes the immune destruction and progresses into clinically evident oral squamous cell carcinoma. The diagram summarizes complete journey of cancer immune editing. Let's follow it step by step. Under the influence of carcinogens, radiation, chronic inflammation, inherited mutation, and viruses, the cells become transformed into tumor cells. Notice the genetic change that shows p53 loss, RB reduction, RAS activation. These transformed cells now express the tumor antigen and danger signals. The immune system immediately reacts, both innate and adaptive immunity becomes activated. Natural killer cells, CD8 cells, gamma delta T cells, macrophages, and natural killer T cells attack the tumor using molecules like interferon gamma, perforin, and TREL. If this response is strong, the tumor cells are destroyed completely, leading to protection, but some instances cells survive. Here the immune system controls the tumor growth but cannot completely eradicate it. During this prolonged battle, the immune pressure selects stronger and more resistant tumor clones. Finally, the resistant tumor cells enter the escape phase. Now the tumor microenvironment becomes immunosuppressive. The regulatory T cells increases, natural killer cell activity decreases, MSC class 1 expression becomes low, and checkpoint pathways like PD1 and PDL1 suppress the T cell function. So the entire process explains an important concept. Initially, the tumor system protects us from the cancer, but over time, tumor cells adapt and evolve and finally escape the immune destruction. Moving further, I will be discussing immune profiling and prognostic marker in OSCC, including HLA class 1 and antigen processing machinery pathway, cumulative suppression index or CSI, important immune surrogate markers, and genomic instability and its role in creating an immune cold tumor microenvironment. This illustration explains the immune profiling in OSCC through HLA class 1 and antigen processing machinery pathway. The tumor antigens are processed and presented on HLA class 1 molecule, which activate CD8 T cell for tumor cell killing. Tumors with high HLA-1 and APM expression are called immune hot tumor and show better immune response and prognosis, whereas tumors with low HLA-1 and APM expression are immune cold tumor associated with immune escape and poor prognosis. Cumulative suppression index CSI measures interaction between CD8 T cell and suppressive FOXP3 positive Treg cell. High CSI indicates strong immune suppression and poor prognosis, while low CSI is favorable. High CD8 T cell density and increased CD57 positive natural killer cell infiltration correlates with improved survival in OSCC. The balance between effector immune cell CD8 plus natural killer and suppressive cells with TREGs determine the tumor control and patient outcome. This diagram summarizes the importance of immune surrogate markers in OSCC. High CD8 T cell infiltration indicates strong adaptive and anti-tumor immunity and better prognosis. Low CSI reflects less immune suppression, whereas high CSI indicates strong TREG-mediated suppression and poor prognosis. CD57 positive natural killer cell contribute to innate anti-tumor activity and are associated with improved overall survival. Genomic instability. Role of T53 mutation in creating immune cold microenvironment. TP53 mutation leads to reduced HLA1 and defective APM, leading to poor antigen presentation, leading to reduced CD8 T cell infiltration, reduced TREG, MDSCS, interleukin 10 and TGF beta, which are anti-inflammatory cytokines. They lead to immunosuppressive microenvironment and creating immune cold tumor. This leads to immune escape and tumor progression. Now coming to immune therapy, there are different modalities of immune therapy such as checkpoint inhibitors, CAR T cell therapy, targeted therapy, natural killer cell therapy, cancer vaccine, dendritic cell therapy. I would like to quote James and Tosuku where they say tumors escape destruction by exploiting immune checkpoint pathways, while checkpoint inhibitors restore the immune surveillance by reactivating the exhausted T cells. Checkpoint inhibitors. Here you can see PD-1 receptor present on T cell and PD-L1 ligand on tumor cells. What happens is this PD-L1 binds to PD-1 and this T cell is exhausted and T cell loses its capacity or ability to kill the tumor cell. So here comes checkpoint inhibitors, PD-1 blocker. This PD-1 blocker will bind to PD-1 and now the cell has its ability, the T cell has its ability to kill the tumor cell. So I talked about checkpoint inhibitors. So are there any actual human studies published using this method or working on this? So yes, a study was published by American Association of Cancer Research highlighting breakthrough involving intralesional nivolumab therapy for high-risk oral dysplasia. The sample was 23 high-risk patients. Instead of systemic administration, a low-dose nivolumab is injected directly into the lesion. The aim was to convert immune hot lesion by locally blocking PD-1 pathway. This activates CD8 T cell, enhancing antigen presentation, increased dendritic cell activity, and strengthens the local immune surveillance while minimizing systemic toxicity. Following were the clinical outcomes of intralesional nivolumab. The major findings were 85% of clinical response rate observed in treated lesion, an average size reduction of approximately 60%, that means more than half the size of the lesion was decreased. 41% of the lesion downregulated histopathologically in severity. The treatment demonstrated immunological effects such as increased CD8 T cell infiltration, enhanced interferon gamma signaling, activation of local immune surveillance pathway, and reversal of T cell exhaustion. Another emerging immunotherapy strategy is CAR T cell. In this approach, the T cells are first isolated from the patient. These T cells are then genetically engineered to express chimeric antigen receptor or CAR, which specifically recognize tumor antigens. The modified T cells are expanded and reinfused back into the patient. The major advantage of CAR T therapy is these T cells can recognize and destroy the tumor cells independent of MHC presentation. Targeted delivery to the tumor microenvironment. Nanomedicine is like a vehicle delivering medicines to desired sites, and this uses platforms such as liposomes, gold nanoparticles, polymeric nanoparticles. The major goal is to maximize the local therapeutic effect while minimizing the systematic toxicity. The system can overcome mucosal barriers and allow precise immune modulation within the tumor microenvironment. That is why Omid Farrokhzad says the future of cancer therapy lies in precise delivery system capable of reshaping the tumor microenvironment. To conclude, oral squamous cell carcinoma is highly heterogeneous and therefore there is no single therapy that is universally accepted for every patient. Tumor microenvironment differs from patient to patient and significantly influences the treatment response and prognosis. The future management strategies will likely involve a multinodal and personalized approach integrating tumor genomics, spatial immune profiling such as CSI, checkpoint inhibitors, and nanomedicine. A better understanding of tumor immune interaction will help us move from reactive treatment towards early immune interception and more effective personalized care. These are our references for the seminar. Thank you everyone for your patient listening and attention. I hope this presentation provided meaningful insight into how tumor interaction influence cancer progression and treatment response. Thank you.